This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast. Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors. A place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk. In this episode, we welcome back Dr. Adam Murphy. Dr. Murphy is a distinguished professor of health equity research in urology, preventive medicine, cancer epidemiology, and prevention at Northwestern Medicine in Chicago. He has been studying the health disparities faced by minorities in prostate cancer, looking at the role of vitamin D deficiency, genomics, and biomarkers in disparities for men at risk of and already diagnosed with prostate cancer. Dr. Adam joins us today to further his community outreach and to continue his mission of education and prevention. Now let's welcome back Elle and Shay.
Let's shift the conversation to this latest American Cancer Society report that indicated an increase in prostate cancer. Of course, you know, they are monitoring various types of cancer, cervical cancer, colon cancer, and whatnot. And in general, and I'm not going to try to recap the report, but generally speaking, the occurrence of cancer in the general population over time has improved. You know, there's less and less incidence of cancer. However, this latest report indicated that for the first time in 20 years, there was an increase in the incidence of prostate cancer. So could you give us your perspective on why you think that's happening? And then what can we do collectively, Shay and I and our podcast, what can we do to help solve that issue?
Yes. So this is an interesting statement again you all are asking, because there's two sides to this story. So the U.S. Preventive Services Task Force was charged with making recommendations to the government about what Medicare and Medicaid should cover, right? Mm-hmm. For screening services. And because of the fact that most men who had low-risk prostate cancer were being treated with surgery or radiation, that over-treatment of cancer and all the side effects that came along with those treatments, the erectile dysfunction, the bowel irritation, the urinary frequency where you pee too much, or the loss, having some anemia from the radiation, having some fatigue from androgen deprivation therapy sometimes, all the things that came along with those treatments, they felt like there was over-treatment and over-diagnosis of prostate cancer. And so because of that mismatch between the benefit versus risks, they said, stop screening, right? Mm-hmm. Stop screening, and they gave it a D grade out of an A, B, D, F. They gave prostate cancer screening with PSA a D.
Wow. Because it was overused?
And they said there was not the harms were not outweighed. They were outweighing the benefits.
Okay.
And so that happened. And so what you'd expect to happen is that if you stop screening for prostate cancer with PSA, you're going to detect people later when they're symptomatic, and you're going to get more aggressive disease because that's what you're detecting. Right? You're not screening anymore. You're going to find when they're symptomatic, when they are having weight loss, bone pain, or they have some urinary symptoms and someone feels a nodule in their prostate. They get prostate. Anyway, you get symptomatic prostate cancer, and therefore you're no longer curable. oftentimes, the mortality rate goes up. So people who were pro that decision really thought this is great because this is what's supposed to happen. You avoided treating all those people who did not develop those symptoms. They die of other things. And only the people who were going to get that prostate cancer got it, right? Mm-hmm. That was the concern. That was what they wanted to see. And epidemiologists were happy with that outcome because you spared people with low-risk prostate cancer who would die of something else anyway from having to even know that they had prostate cancer. And therefore, they live their life living happily ever after. That's the theory, okay? Mm-hmm. Now, the danger of that was that at the same time, urology was building data on the strengths of active surveillance for early prostate cancer, where you could safely watch people over time by following their PSAs, following their rectal exams, getting repeat prostate biopsies. And then now with MRI and biomarkers, you can even use those tests to see if the cancer is getting worse genomically with the way their genes are expressed in the tumor, or if by imaging their tumors are growing or becoming concerning in other areas of the prostate. So we think that they threw the baby out with the bathwater.
Right.
And got rid of PSA screening right when we were about to get really great at it.
I do have to get back to this PSA. I'm so sorry. So, because I want people to live. So, Dr. Adam, if a patient came to you, would you recommend that they get a PSA?
Yeah, oh, no. Yes. I'm sorry. Let me make sure that this is unequivocal. Yes. People should be getting PSA screened in their 40s. But it should be, I do think it should be shared decision making. There are people whose values don't want to deal with potential side effects, even if they were diagnosed. So it is a shared decision making conversation. Mm-hmm. Yes, I recommend PSA screening for men in their 40s. And then if they have, and any man who still has 10 years life expectancy left in their life, whether they are 60 or 80, should still be talking about this with their doctors.
Okay. All right. And then I have another question. Now, for example, Elle, what was your PSA level when you were diagnosed with prostate cancer?
Well, I think it was probably like in the 7 range.
Okay. All right. So it was like around 7?
Yeah.
Okay. So Dr. Adam, here's another question.
Well, one thing I want to highlight. It ended up at 7, but previously it was like, 1, 2, 3. So the incident that happened to me wasn't so much as the final level being 7, but it was the rapid increase in the PSA level. So I was very conscientious about getting my PSA tested, and I was going like every 6 months. All right. And I went, and I specifically remember I went in July of 2019 and June of 2019. And then I went back in January of 2020 and my level had increased like 15%. And then my urologist that I was seeing at that time told me to come back in 4 months instead of 6 months. And then it went from, it had increased by another 17%. So you had a 15% increase, 17% increase within, like a 6 month period of time, which took me to the level of 7. And that was the increasing level was more so the signal than the final number.
Right. Okay. So Dr. Adam, Elle has a friend, his PSA level, this is unbelievable. I didn't even think it was a true number. It was like 70, but he doesn't have prostate cancer. Explain that to me.
The prostate is really an interesting organ because it varies in size quite a bit between men. Mm-hmm. I've seen ones that are like, 10 grams in size and some that are like 230.
Wow.
And so, you know, I have a big head, and there's people I know who have a small one. I get jealous of the small-headed people.
Mm-hmm.
But if my head was producing PSA, I'd have a higher PSA than the little head friend of mine. Okay,
Mm-hmm.
bigger prostates make more PSA. That's one reason. Some people have a lot of inflammation in their prostate.
Okay.
And that could be from sexual activity. It could be from they got unfortunately some parasite or bacteria or virus in their prostate that stimulates their immune system so much that it makes the blood vessels in there leaky to PSA.
Oh.
So that those people will pump out more PSA into their bloodstream
Mm-hmm.
because of the inflammation that's at their prostates. And that's not uncommon. It's called asymptomatic inflammatory prostatitis, and it's actually the most common cause of elevated PSA. So benign prostatic enlargement is one, with just the size. And two is this inflammation that happens. And then three, people can just have high PSAs with sexual activity, masturbation, oral sex, whatever type of sex they're having. Mm-hmm. You squeeze on the prostate, it increases the level for a couple of days. And if a guy is having anal sex and being penetrated, that consistent bumping against the prostate can raise that PSA level for 4 days.
Okay. So in essence, it is possible to have such a high PSA level and not have prostate cancer.
It's possible.
Okay.
The other thing that causes it in men is urinary retention.
Okay.
Where these people can't pee, and so they have so much pressure on their prostate that it squeezes out into the bloodstream.
Okay. All right. Well, I believe him now then.
Yeah.
Because when he said it was 70, I was like, he has to have prostate cancer. So it is possible that it could be that high and he doesn't have prostate cancer.
You're not wrong, though. His likelihood is probably in the 80% range of having prostate cancer with the level that high, mm-hmm. maybe even higher. But there are exceptions because of the fact that other things could be at play.
Okay.
If you have advanced prostate cancer, you know all about perseverance. You believed in your team, even when it hurt. You met the challenge piece by piece. You didn't quit then. Don't start now. If you've had hormonal and chemotherapy, ask your doctor about Pluvicto, a different type of treatment for PSMA-positive metastatic prostate cancer that targets PSMA-positive cancer cells so you can be you for longer. And that's no small victory. Pluvicto involves contact with radioactivity, which may increase the risk for cancer and cause fetal harm. Drink plenty of fluids, urinate often, use contraception, and talk to your doctor about ways to reduce the risk of exposing others to radiation during and after treatment. Pluvicto can cause low levels of blood cell counts, kidney problems, and infertility. Tell your doctor if you have weakness, pale skin, shortness of breath, bleeding or bruising more easily, an infection, or changes in urination. Side effects include tiredness, dry mouth, nausea, appetite loss, and constipation. Here's to never giving up. Ask your doctor about Pluvicto for more everyday victories.
So Dr. Murphy, one of the things, again, like we want to do is impart information, and we want to motivate people, men and particularly Black men, to get more, become more aware of prostate cancer, prostate health, learning what the warning signs can be and whatnot. We talked about this before, but let's just recap this for a second so that our new listeners may benefit from your expertise. So if I'm a guy and I'm listening to this and I'm like, man, I wonder if I have a prostate problem, whatever. How do you know? How does a guy know, other than going and getting a regular PSA test and whatnot, but just in your everyday life, how would a guy know that he's headed for some trouble with his prostate?
So I have to just say that the whole purpose of screening is to find asymptomatic men by the PSA test so that you detect prostate cancer when it is curable, which is 99% curable when you detect it early, and only 25% curable when you detect it late. So I just want to say that that's the number one thing is really doing the screening with your primary care doctor and getting a primary care doctor is probably the biggest thing that you can suggest to someone else. But in terms of symptoms, who's at high risk? If you have a family history of other cancers like breast cancer, colon cancer, prostate cancer, ovarian cancer, certain genetic syndromes for cancer syndromes, you should be on alert to say that even though your mom had breast cancer or ovarian cancer, you could very well have gotten prostate cancer from her genetics. Obviously, your biggest risk is if someone in your family, a brother, father, even second-degree relatives to a degree will increase your risk of prostate cancer. So second-degree are uncles and grandfathers, half-brothers can increase your risk of prostate cancer. And so if you have that in your family, you should be thinking about, okay, I'm at increased risk of cancer, not just the same cancer that they had. So that's one thing. The other thing is if you are having difficulty with, keeping your weight on, you're having weight loss or bone pain or difficulty with urinating or blood in the urine, new leg swelling, kidney pain, like flank pain from the kidneys, those are signs of advanced cancer, and you should definitely come in.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
Okay. And then we talked about this before, the guy at the White Sox game you mentioned who was at the, public urinal and, he was taking, once you become aware of this prostate thing, men have little privacy in the men's room. You notice a guy that's standing up there for a couple minutes or so trying to urinate.
Mm-hmm.
That's a symptom too as well, correct?
Right, yeah. People having issues getting the urine out. Usually it's benign prostatic hyperplasia, BPH, called that. But prostate cancer, if it happens to be in the zone around the urethra, which can happen in up to 30% of cancers in that transition zone, it's not common, but it's possible, can obstruct the urine flow. Okay. So usually it's benign growth, but sometimes it's a cancer there.
Okay. Shay, you good?
Yep. So Dr. Adam, we're seeing or hearing about guys younger and younger having prostate cancer. Mm-hmm. So would you then, based on what you just stated, say that that's probably family related because of maybe the history of their family? Because we're talking to guys now like in their 30s and 40s with prostate cancer.
Yeah, no, and Black men are more likely to have early prostate cancer.
Okay.
But yeah, it is happening earlier. We don't really have a great set of data on why that's happening. I believe it's in part because some people are being screened earlier because of family history, and so you detect them earlier. Some people are so aware of Black people being an increased risk, and they're just being screened earlier by their primary care doctors, or they have a family history and they're being screened earlier. But I believe that the way that our soil is, and our air quality is accumulating toxins, and the way that we eat processed foods, the way that we use plastic in foods, puts additional toxin load on our bodies. Okay. And so I'm a big advocate for kind of eating plant-based, non-processed, more whole foods in your diet, because I just think there's a science paper that came out that showed that the average American diet was faced with 180 different chemicals a day.
Wow.
180. So like you're thinking about the coffee creamers that are artificial that you start your morning with breakfast, and then you may go to Dunkin' Donuts and get some sausage patty that's been processed with a bunch of different stuff in a croissant. And by the way, I'm giving you my life.
Yes.
I've done this in the past. I don't do it now.
We have to. Yeah.
And then you go to lunch and you may eat a bag of chips, or I used to love Flamin' Hot. Don't tell anyone. I used to love Flamin' Hot Cheetos. I would eat these things. My fingers would be red. I'd have to talk before I went to patients' rooms because it was embarrassing. But anyway, this is my stress life. Now that I am a grown up now, I don't do that. But we eat processed food throughout the day, right? And we don't even think about it. The energy drinks that we drink, just the way I used to run on the lakefront, and I used to think about bladder cancer risk for people who are exposed to highway car exhaust fumes. Bladder cancer rates go up over there. So I just know that we're, as a country, experiencing higher levels of toxin burden in our diet and in our soil and in our water and our air quality. My daughter did a soil quality test with Peggy Noteberg Museum, and have found nutrient density goes down, toxin levels are increasing in the soil.
Okay.
Wow.
You said your daughter.
Yeah.
Okay. Well, that's going to be a whole nother show because he doesn't even look like he has a daughter old enough to do, you know.
She's 19.
Okay, still.
He's very smart. Both of them, yeah, I'm lucky to have 2 smart children. Yes.
Okay, awesome. That's awesome. Okay. All right. Yeah.
So as we draw toward our conclusion, one of the things that we want to make sure that we're doing in our theory is that, you know, there is no shortage of information out here on prostate cancer and on health in general. Yet and still, people, men, Black men in particular, are not going for their PSA tests or not paying enough attention to the health in general. So it's not for lack of information. We theorize that it's the messenger and it's how the message is being conveyed. And that's why we started this podcast.
Yes.
So that we could deliver the message in a more down to earth, if you will, manner, with a more casual conversation with people like yourself. So as we conclude our conversation, what are your thoughts, Dr. Murphy, on how we can increase or continue to convey this information in a manner that is actionable, something that men and their families are going to, first of all, listen to, engage with, and then act on? What are your thoughts on how we're going about doing this and any suggestions you might have into carrying out this message in a more effective way?
You know, I really wish that there were ways to get this message out better. I think your podcast is a good example of this that needs to be expanded, because I feel like it's got to be able to reach people in a relatable way. The thing that happens, I think, in a lot of educational spaces for prostate cancer is that if you look at the reading levels on these websites, it's pretty high. It's not, I mean, you're in advertising, you're a businessman, you can read and do well with this information. And, you know, obviously you put this whole show together with your wife, so you all are pretty savvy people. The average person does not read these websites, right? Even if they went to look at the websites, it could still be overwhelming. So what you all are doing and making it relatable through regular conversation, I think is a key feature of what you're doing. It's the fact that it is a conversation. It's not, I have a PowerPoint and I'm telling you, you know, the latest with this research study. You know, Shay's talking about personal anecdotes for the guy with the PSA of 70 that she saw in your life that feels more urgent than the data I'm going to put on a PowerPoint slide. So I think just keep doing what you're doing is one thing. I still struggle to get Black men to know what their prostate is.
Right.
So I think we have to put it in the places where people are looking, and that is in real TV programs and things that are entertaining and things that are very, very, very readily apparent. Like I would love that. This guy used to have this idea that I met. He wanted a hot air balloon where the balloon was shaped like hairy balls and the basin like a prostate. And I thought that was a little bit wonky. I could see where he was coming from.
Right.
He really wanted me to sign on to this hot air balloon. But it didn't have his point was we need people to see this at the halftime show at Super Bowl to know that the prostate is an important thing, like breast cancer is important.
Right. Yep. And I think, like guys, like, I don't know the hesitation, because women, if you guys knew or could see what we have to do when we get mammograms, when we get pap smears, it's like what a PSA, takes all of like 5 seconds or so. You know what I mean? Like, come on, guys.
I think it's the rectal exam that really deters men.
But how long does it take to do it, though? You know what I mean?
I think it's, again, that information asymmetry automatically sets doctors up with a level of authority that puts the patient at an imbalance.
Yeah.
So if you add race to that grows. If you have socioeconomic class, it grows, right?
Yeah.
So the way I feel about myself as a male, coming out with my ego intact, doesn't like the idea of someone who's more powerful than me sticking a finger up my behind.
Right.
Yeah, but that being said, I do think it's actually, they have to see it from the doctor's perspective. We don't actually like putting our fingers in people's.
Right.
If the guy could put the prostate behind the ear, it'd be so much better for me.
Right.
You're right. Just go ahead and just tap right here. It's just where, the universe, God, nature put the prostate.
Right.
And so we go for it. I think that people think that we're getting some kind of power trip or power, I don't know, or disempowering them. I don't think of that at all.
Exactly.
We don't enjoy that process.
Right.
We do it because we think it's helping our patients. So I do get why men have an issue with it, but I just think the more threats you have on your own sense of maleness and self-esteem and ego, the more threatening that rectal exam becomes. And if you've been molested or harmed in some way, then that goes up.
As we begin to close the show, we hope you enjoyed this episode and recommend subscribing so you don't miss out on anything new.
Well, we need to continue to make it marketable, so to speak.
Yes.
This is why companies have slogans and spokespersons and whatnot. Of course, they're not selling a prostate exam, but to some extent possible, where we can talk about this 5 seconds that may be saving your life.
Exactly.
And to simplify the message in a way that equates those 5 seconds to saving your entire life. Okay.
Yeah.
Whether it be through a blood draw or the rectal exam or whatever. So with that, Dr. Murphy, do you have any final words that you'd like to leave us with before we depart?
Yes. Just to wrap up the unclear parts of the discussion, PSA screening should be done for all men. I believe it's starting at age 40 to see how you should be screening. I think that men should be advocating for their own PSA testing with their doctors, because the government right now does not require primary care doctors to offer PSA screening. And so sometimes patients are going to have to stand up and ask for something, even though their doctor isn't going to recommend it. They usually trust their doctors to just go ahead and do that, right? That's something that we're not advocating for right now in terms of PSA screening. It's going to vary from doctor to doctor. And then I would say clinical trials really are a great equalizer of care. There's very rarely a placebo trial now. There's usually standard of care treatment versus standard of care plus something else. So it's because of the ethical regulations of research now, it's much safer to be in a trial now, like much, much safer. There are whole jobs dedicated to auditing the fairness of trials. So I just think that those are probably my takeaway messages from today. And yes, the decrease in screening has led probably to the increase in prostate cancer mortality rates that are not helping Black men do better. So that's why we need to have people advocate for themselves.
Okay. Well, Dr. Murphy, we really appreciate you as always, being a member of the family now.
Where's my Christmas card?
Oh, you're getting it. And look, okay, listeners, notice Elle says Dr. Murphy. I said Dr. Adam. So it is Dr. Adam Murphy, guys. Okay. Just to be clear on that, we're talking about the same doctor.
Yeah, no, I get a lot of requests for Dr. Adams. I'm like, no, not that.
So it's Dr. Adam Murphy.
Adam is his cool name. That's the cool.
No, I appreciate it. Like I am fine being called Dr. Adam or Dr. Murphy. Both of them work. I just think that it's, at least I like it, the Dr. Adam part, because it feels like I'm a person first. And my profession helps me be a person better so that I can help other people be better persons themselves, you know? So I don't mind being called Dr. Adam at all, but Dr. Murphy's my name. I go by that too.
Okay. And look, and if Courtney B. Vance ever need a double, he's here for that too. Dr. Adam, thank you so much. God bless. And it's always a blast talking to you.
That's good.
Look, and I learn a lot each time.
You know, I think what you're doing is basically telling me what the gaps are for real people, because you all are talking to real people outside of an office. And so it's really nice to kind of hear your perspective of it too. I learned as well.
Okay, thank you. Thank you.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, elleandshay@prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, @prostatecancerrealtalk.com.